Okay, everyone. It's good to be back with you again. It's September the 13th. Can you believe it or not? But it's always good to join you. I appreciate your time with us on this virtual town hall, living with lupus and COVID-19 in our community. Again, a shout out to Terry and the gang at the Lupus Foundation Georgia chapter, the Georgia Council for Lupus Education and Awareness, headed by Chris Reed and supported by Representative Kim Schofield and others. And then I lead a team at Emory, especially the Georgians Organized Against Lupus research group. Please take a moment to just look at the disclaimer on the website. Just know that none of this is meant to be specific guidance to any individual, but always check with your physician to make the best choice for yourself. The latest counts worldwide shows that globally there's over 28 million cases and 913,000 deaths. And you see the US with over 6.5 million confirmed cases and over 196,000 deaths. India has taken over Brazil as number 3, but the USA, India, and Brazil comprise the majority of the cases and the deaths throughout the world. But you see the rest of the countries that are in the top tier, if you will. The map representation here, you can see what I showed in the previous town hall compared to this past week on the right. And a lot of the major hotspots remain, as you can see, especially the US, parts of Central, and then most of South America. And then you see India and then the Middle East. But one thing to point out here is, though Europe appeared to have the virus under control after a devastating spring, countries there are again struggling. France reported a one-day record total of 10,560 some odd cases, new cases, on Saturday alone, rising by more than 1,000 from Friday. In the United Kingdom, which has suffered Europe's deadliest coronavirus outbreak, recorded more than 3,000 new cases for the third day in a row since the 1st of May. Spain is having a hard time controlling some of their outbreaks, and Austria says it's seeing a second, quote unquote, second wave of infections. So these are good lessons to learn for all of us, in that just because things start to improve doesn't mean that it can get worse again, can't get worse again. Here in the United States, you can see the map on the surface, essentially looking the same from the previous town hall. But one thing I'll point out, though, is if you just sort of focus along the southeast where we are, the density of the red hotspots from the previous town hall isn't quite there, which is good. I think it'll signal what I'm going to show you in a minute, that we are reflecting general downtrend of cases that the entire country has been having. But what you see still are obviously a lot of hotspots. And if you can imagine, you might imagine that the center of most of the red is starting to shift from the southeast more towards sort of the middle Tennessee Valley and the Mississippi, and then going up to sort of the Dakotas. We'll touch briefly upon that in a minute. So generally, cases are going down, which is good throughout the country. And you can see that the downtrend persists. Again, we're still not at the point where we were initially in the pandemic, and it's still very high, but it's good to see that the trend continues from what we've discussed before, that the new cases are going down and the deaths, as you would expect, to go down a little bit as well. California, Texas, and Florida are still the leaders in our country in terms of new cases. Georgia was actually very high up there. As you may remember, in a few weeks ago, Georgia was like number 2 in the number of cases, or 3, and then number 1 at one point in the number of new cases per million. We've dropped since then, which is good, but we're still in the top 10 in both regards, so we're still relatively high. A lot of the spike in cases are being driven by young people in this second or continuation of the first wave, if you will, as I've discussed in the past weeks, but especially recently since school has come back into play. Colleges in particular are really driving some of the areas, and I'll touch on that again briefly. You might have heard about the vaccine that is being produced by a company called AstraZeneca. That was produced in partnership with Oxford University in the United Kingdom, was halted briefly because of an unexplained event in a patient at that time. And it's since then been reviewed by independent groups, and they have restarted the study in Europe as well as just recently in the US. On one hand, again, we'll touch upon this as the vaccine season approaches more, especially hopefully when we get closer to the COVID vaccine. But I hope this gives you a sense of the process in play. These vaccines are worth literally billions of dollars, and any edge that a company can have over another will have tremendous impact along those lines. And to have one of the earlier studies that had a lot of good hype to it get halted briefly because of one person, it tells you the degree of oversight that really all studies have. And in this case, what happened was there's an independent group of people called the Data Safety Monitoring Board. They are unknown directly to a lot of the gatekeepers of the studies, the financial holders, the stakeholders in that regard. Their only role is to independently look at the data that's coming out each and every week and month and see if there is some sort of signal to things. And it doesn't even have to be one bad event. It can be sort of even a rise of sniffles or rashes that otherwise would not be explained. They see it more in the group with the vaccine compared to the ones without, or the placebo group. They have the power to stop. And I think this case was severe enough that they wanted to just hold for a second and decide whether it's something that is serious enough to cause even more concern about the safety of the vaccine or not. Now, with these tens and tens of thousands of people in these studies, just on chance alone, and given all the other opportunities to become sick and have issues arise in the general population, you're going to expect some of these things. And how to discern that from a reaction to a vaccine is definitely part of what they're putting into play. And there's a lot of scientific thought involved in that, including statistics and so forth. The other part, though, that I read in the New York Times today is that they are concerned that the companies are not being more transparent about the details. And it would be good to know what unexplained event means. I did see, I think, on one news report, although I haven't really seen it on too many other reports, that this one event was a transverse myelitis, which actually can occur as a part of lupus. And it doesn't mean necessarily that these vaccines will be bad for lupus, but some of you may have heard this term. It's an issue with the spinal cord and inflammation there. I'm not sure if that's what it was, but that's part of the issue. If we don't understand or know what these specific issues are, it doesn't really go a long way in getting more trust in the general public and the scientific community. But it's not to say that the process isn't good. It would be good to be more transparent. And to be fair, what they're doing really isn't different from what's been done all along. These companies do, again, have a huge financial stake. And because of that, they don't want to reveal too many details to the competitors. But I think the argument here is, obviously this is a very extraordinary time. And plus, these companies are getting tremendous amount of public support, especially in terms of dollars from the governments. And so there should be more transparency in that regard. We're waiting to see the impact of the Labor Day weekend on new cases, and it's a little bit early to see that now, but over the next week or two, we'll be able to gauge that. And kind of what I talked to you before about people with lupus starting to come in with a lot of severe issues because of delayed care and access to medications and so forth. The dentists are also starting to see a surge of issues because people have delayed care, been concerned about going to their dentist. So this is kind of a general issue. So one of the issues that may be driving this, the number of cases that are occurring, especially in the Dakotas or the north central part of the US, are events like this. You might have heard of the Sturgis bike rally that occurred. It was a rally that happened in the Dakotas, which drew nearly 500,000 people over 10 days that came from all around the country. And it was a biker rally, as you can see here. And there was a study that was released late last week by 4 economists from the Center of Health Economics and Policy Studies at San Diego State. And they estimated that over 250,000 new cases nationwide resulted as a part of this mass gathering where there was hardly any social distancing or masking involved, and it resulted in billions of dollars in healthcare costs as a result of that. Now, some of this has been tempered by the fact that there was a subsequent Johns Hopkins evaluation of how this other group did the study, and they had some questions about the methods, but the numbers and the impact the numbers specifically may be in question, but the impact never was. Clearly, this was a direct result of an increase in numbers. There's just a question of the magnitude, but there was a significant increase in numbers. There clearly was a certain degree of COVID in the community, and there was a large increase after this event, and that's not a surprise to anybody. So the bottom line is, these events, we can talk about all the little details and so forth, but they're not helping the cause in terms of keeping the cases down. So in Georgia, you see here, this past week compared to the last town hall a couple of weeks ago that I presented, and the difference here, well, the similarity is that you can continue to see that relative to the Metro Atlanta County, the other areas, meaning the rural parts of Georgia, continue to have a large burden of the high frequency of new cases or the hot spots. Along the lines of what we're seeing throughout the country, I'll point out 2 areas. You'll see this dark red spot here, and you see some of the darker spots here. And some of you may guess already, but what they represent are college towns. UGA is here, and then you have Georgia Southern and other colleges in this area. So, that again is kind of a common theme that Georgia is reflecting from what we're seeing nationally, is that there's a large number of cases being driven by these young people, especially in the colleges. Here you can continue to see the high impact counties throughout our state in terms of the number of new cases per 100,000. And Chattahoochee and Stewart, I mean, I really need to kind of look into why exactly they continue to constantly lead, but they have a huge burden of cases there, but you still see a lot of other counties that are disproportionately afflicted as well. And along those lines, and it's just a constant reminder that these are counties with a high number of minority communities, especially of African Americans, and then other counties with Hispanics. They continue to bear a large burden of not only the cases, but what continually is being overlooked or not emphasized enough is that even though these cases are going down in total number, the burden in certain communities, especially our brothers and sisters in the African American community and the Hispanics, it's still a disproportionate burden. And then especially in regards to deaths, there continues to be a much larger rate of deaths in African Americans compared to other groups. And we need to continue to be outraged at that and bring that up to the national consciousness, because we should be, more than anyone else, be sensitive about that, because these are the same themes that we have in lupus. And they probably, and in fact, I'm positive there are similar factors driving it in both cases. And so, if anything, if we're going to do any better in lupus, we need to do better with how we're doing with COVID. And it's just an example of what we need to do in the future together. So Georgia, in terms of reported new cases, continues to go down, which is good. And the deaths are starting to come down, whereas last time I reported, I wasn't quite sure what this signal meant, and it did indeed go up for a little bit, but it's now starting to really come down, which is good. So let's hope and pray it will continue in this trend. So the overall kind of threat level, if you will, Georgia continues to remain above the halfway mark, but we're not at the highest mark, which is good. The daily cases continues to be very large, and we need to focus on that. But the infection rate has been decreasing. The number of positive tests are down to the 5 to 10% that we want. Lower the better, obviously. And in terms of being concerned about overwhelming the intensive care unit beds or the hospitals in general, we've lowered that to the point where that's not as much of a concern. So you can see that the hospitalizations in general have come down throughout the state. But again, pointing out, they still have not reached to the point where at the lows after the initial rise in cases. So they're still relatively high. It still should be unacceptable as a whole, but comparing to what we were just a few weeks ago, it's encouraging. It continues to be encouraging. So we need to continue to be vigilant, as the examples from other countries have shown, and what will happen in our country soon too, in terms of areas getting better and then getting worse again and then better. We just really need to minimize the swing, if you will, and continue just to maintain and hang in there and do our best as a community as we go through the coming fall and winter. Now, going to some quickly, some general things before I move to the questions. I saw this article that looked at where the prescriptions for especially hydroxychloroquine came from when at the height of the hysteria around hydroxychloroquine in March and April. And most of actually more than half of the hydroxychloroquine and chloroquine prescriptions were prescribed from primary care physicians. And that's not the case normally. Most of the prescriptions clearly come from rheumatologists and some associated specialists. A very small percentage comes from primary care. And so you can guess that what was driving all of this is this hysteria. People who really should not have been getting it, the hydroxychloroquine regularly to begin with, were going to a lot of sources, including primary care doctors, who were prescribing it without any data. And we look back and we were cautioning about this hysteria, and unfortunately we were right, most of us anyway, that clearly it's not a drug that is safe to use or should be used in really sick people with COVID. And there's been absolutely no hint that it's a protective drug for people who don't have COVID, but are trying to prevent from getting it. And that's all along the lines of this infodemic that we're fighting. So it's not just this epidemic of the virus, but it's this epidemic of misinformation that is out there. And obviously the issue is not new, and social media is very powerful. But unfortunately, when you mix COVID and misinformation through, especially social media, you have you have a contribution literally to the deaths of thousands. So let's do our part and try to fight against that. Although it feels very challenging, isn't it? Because there's so much of it and it spreads faster than the virus itself. And what we can do is exactly what you're doing, not just this town hall, obviously, but um, you're educating yourselves, you're arming yourselves with information from trusted sources. You're making the best decisions for you and your family based on the solid information that you know. And hopefully you're spreading that to your family and friends and others so that we can counteract a lot of the fake information that's out there. So we have 4 questions today. First, do you think there's going to be a second wave this winter, and when do you think it'll start? So think about the flu. Again, COVID is a respiratory virus just like the flu. And so what are the factors that drive the season for flu? And it starts right around now and through the winter and into the early spring. And so what is it about these times? It's not necessarily the temperature, unfortunately, for COVID. As we found out, the summer heat doesn't do that much in terms of transmissibility for COVID. But what COVID and the flu will share is that because this is a respiratory virus, you need people around, you need it in the air, you need to get it from an infected person, these droplets into another person's airway system. And that requires people who get sick, who cough, that are close to each other. And that just happens a lot more in the wintertime in general. So we're not as outside as much. For those of you that have been going to some events or to a restaurant, I mean, we have hopefully more, you've been seeing these options to be seated outside, and that helps somewhat. It's certainly better than being packed inside. But when we start hitting 20, 30 degree temperatures, people are going to be inside a lot more. It's the height of the school season, so things get transmitted a lot easier that way. And so we'll just have to wait and see what happens. On the other hand, we are masking more, and we are more cognizant about being clean. And so the previous flu seasons, the rules are slightly different. We were not as attuned to these issues about respiratory viruses in previous flu seasons. And what's happened in Australia, since they're just coming out of their winter, is that they actually had less flu than before, again, probably because of all what we're doing for COVID. But Australia is different from the US. I mean, they had actual nationwide mandates for masking, social distancing. They levied strong fines for people who did not comply. And here, we're in a country, obviously, that has very scattered and different rules throughout even regions. And so how that's going to pan out into what we look like as a country going into the winter and the flu season, no one will know for sure. And so there are reasons to be concerned. And it wouldn't surprise many to see another spike in the winter for all these reasons. But again, I'm cautiously optimistic. There are other reasons that those things could potentially be mitigated, or these risks could be mitigated or reduced, so that somehow we may not be as worse off as many are fearing. As a lupus patient who's been doing generally well, should I request those who wanting to visit be tested prior to coming to my home? And likewise, when I visit others, especially for those, or including those coming from out of state. So whether it's from out of state or not, and just anybody from outside of your home, or whether you're going to someone else's home, there are a lot of different factors. I mean, whether you have to do it at all, and it's not to judge anybody needing or wanting to get together, but that's obviously a factor. And if the bars change in terms of what really drives us in terms of assessing important reasons for getting together. But if you do choose to do that, then it's going to depend on the community spread in the areas from where the people are coming. So that gives you sort of a sense of the risk of the individuals involved. If people are coming from areas where there's really high spread, they may be doing very well themselves, but again, it's just statistically increased that they may be exposed to people around them that are sick. And so with that increased risk comes the increased risk of them transmitting potentially to you. So that's when, I think the testing does come into play. And so until we get vaccines that are safe and effective, that are distributed throughout the community in large numbers, then if you do have to meet, testing as part of, I think, the tool that you can have. I'm sorry, one step before testing is you also want to think about the people and how well they've distanced themselves from others. So I think if people are generally working from home, not going out that often, from a community that doesn't have that many COVID infections, and they've done that for at least 10 days or so, and I would still test them if possible. And if they have a negative test on top of that, I mean, you're pretty golden. Um, uh, and then, I think where testing comes into play is that there is a lot of access now to testing. There's different types of tests. The ones that you heard about that really go up the nose, it's a PCR test. It takes a little bit longer, and at the height of the shortage of the supplies and access to these tests, we were not getting results back for a couple of weeks, and that was pretty much useless. But I'm hearing now that it can come back in about 3 days or so, which is, if you have the luxury of doing that, that's the best way to know if someone's an asymptomatic carrier, or if they're symptomatic, they're actively infected. But there are other tests out there, including a screening test that some places have, that the accuracy seems to be pretty good. They're still working it out. But if you have a low risk individual, like I said, someone who's been relatively isolated from a low risk community, you can still have them go get the rapid screening tests. They don't require anything like going straight up your nose. It's just sometimes the new ones out that are starting to go out just require a saliva sample, but you can get a test result in a few hours at the latest, either free or a relatively low price. And again, it depends on access and availability and maybe some insurance. But I would recommend, especially if you're going to have a larger group, to really intermingle. Again, thinking about the risks involved, from where they come from, the chances of them interacting with other people that are exposed, having a test, and thinking about the type of test that you're doing. And then even once you pass all of those hoops, I would still try to practice as much as you're able to the social distancing and the masking, especially. I know it's a tough call sometimes, especially when you're inviting people into your home from out of state. It's a social gathering, and then to say, let's put masks on. But again, I'm talking to an audience that's more sensitive to lupus issues. And even though you've generally been doing well, we don't have anything to take certain lupus patients out of the high risk group. So we don't fully know all the information. And I think the best thing would still be, even after you pass the hoops of defining the type of people, minimizing the risks that are coming to your home, and getting some type of screening testing, that to the best of your ability to do social distancing and masking, even within your home. When's the best time for me to have my flu shots? And when a vaccine for COVID becomes available, should I get one since I have lupus? So flu shots are starting to be available now. They're available in some pharmacies and Publix. And generally speaking, you should get them when you can and as soon as you can. One possibility, especially at Emory, where I work in the healthcare system, we actually don't roll out the mandated flu vaccine for the healthcare workers until another month or two. And I just learned recently the reason that they're doing that is they're trying to make sure that we as healthcare providers maintain immunity all the way through the flu season, which can go into the early spring. So theoretically, it depends, how long. I mean, everybody's different in terms of their immunity to the flu vaccine. But if you want to increase your chance of having immunity a little bit later in the season, then you might want to wait just a bit. But these are, for most people, very subtle details. And the reality is, I think for most people, if you have an opportunity right then and there, and you can get it and it's on your mind, if you're in a Publix tomorrow and you're able to get the shot and you want to, I would not even start thinking, well, maybe I want to have maintain immunity through the spring and I'm going to wait another 2-3 weeks. The risk there is you forget about it, or something happens, or you get the flu before then, God forbid. And you have no idea whether your immunity is going to wane then anyway. You may have great immunity throughout the whole season. So these are all things that on an individual basis, I wouldn't worry about. So generally, especially for the flu vaccine, we have good experience with the flu vaccine in people with lupus. It doesn't trigger flares. So unless you have a reaction that you would have gotten anyway as a person without lupus, if you have an egg allergy or something like that, if you otherwise tolerate it, you should get it. Now, the COVID vaccine, just because the flu vaccine in general is well tolerated by people with lupus, doesn't mean the COVID vaccine will be either. So that's going to be a question that I think we're going to have to discuss more as these vaccines start coming out. It'll depend on some of the early results from the actual study that got the vaccine approved. Let's see what kinds of side effects and in whom may have occurred and to what degree. And then in the beginning, we certainly will have reports of people throughout the world with lupus that get the vaccine. And we'll see if there's any signal in that regard. There may be some very early studies with small numbers of people with lupus, just like there was for the shingles vaccine. I remember that some groups throughout the world were trying to answer that question, whether that's safe in people with lupus. And so I think that'll happen. And again, it depends on your type of lupus, right? Everybody with lupus is different. And if you're really stable just on hydroxychloroquine for many years, you've taken your flu shot for many years without any problems, we look at the early studies and it seems relatively benign. I mean, you may be someone who seems to be at lower risk, but if you're someone very sick with lupus, a lot of flare issues going on, depending on some of the medications you have, I think that's when the discussion needs to be had. But I'll try to relay what general directions I'm hearing as early as possible when that happens, because we will get some vaccine at some point. Okay. Oh, yeah. There's one thing I was going to mention. Keep in mind that there are certain medications in particular that will impact people with lupus and vaccines in general. So in particular, rituximab and Benlysta or belimumab. I mean, belimumab is the one drug that's approved, or the recent drug that's been approved for lupus. Rituximab is used off-label sometimes in people with lupus. These are two anti-B cell biologic medications, and the B cells are involved in creating antibodies, which is also involved in the response, a positive response to a vaccine. So these drugs will have a particular effect on reducing the effectiveness of vaccines, maybe not 100%, but there will be some probably significant decrease in effectiveness of the vaccines in general. So if you are on belimumab, I wouldn't stop anything now, but it's a discussion to be had with your doctor in the months to come as the COVID vaccine comes out, what to do about that, because then you have to weigh the issues with lupus as well. And especially as the months get closer to maybe a vaccine starting to be available to the general public, let's say, fast forward into the spring or summer. For the general public, there's a COVID vaccine that seems to be good and reasonably safe in general, and probably most people with lupus that you're excited to get. And it's coming in the next month or so, but there's discussion between you and your doctor to do rituximab. That's something that would cause some pause for me, I think. You may want to try something else to put off the rituximab until you get the vaccine, and then you wait a few weeks after that, and then you can get the rituximab afterwards. But again, a lot of details to be discussed with your doctor, and we'll bring up some general concepts in the future. When do you think we'll be able to have large group gatherings again, outdoor or indoor? So it's not a black or white question here. Until we have really a lot of safe and effective vaccines out there that people can get, and most people are immunized in some way, we're already having gatherings, right, to a certain degree, depending on areas of the country. And there's some football games that have occurred today. So it all depends on risks and how that's interpreted and what's available and what people are willing to do and what people are mandated to do. And as you can see, it's different, not only across regions of the country, but within states, and not even within just a state, but within actual cities within a state, like Georgia. I mean, it's a classic example. So, and then there's a lot of individual differences in terms of how this data is interpreted and the risks people are willing to tolerate and what they view as essential gatherings or not. So it really is the perfect formula for highly controversial approaches, which we're experiencing already. And I think the question here is, I can appreciate the individual nature of it. I can get a sense of this person and many of us in general just wanting to be able to do this, and to be able to be told, yes, you can do this gathering. But it's not going to be simple like that. It never has been, and I don't think it will be. It will always be shades of gray, and hopefully it'll be clear one way or the other. But until there's high immunity throughout, like we were living before COVID, with the flu just kind of in the background in the community, that can be suppressed to some degree and protected against with vaccinations for most people. It's going to be this type of discussion and what's safest and best for you. Just to let you know, in the city of Atlanta, just a few days ago, on Friday, this Atlanta softened at least one major guideline related to COVID-19, that groups of 10 or fewer people can gather, provided they practice social distancing. And this announcement signaled that the city entered its phase 2 of its reopening plan. So it went from phase 1 to phase 2, and I think there's 5 in total. So we're making slow progress in the city, which is good. It's based on meeting the benchmark of 75 people or less in Fulton County testing positive over a 14-day period, and no more than 200 people being hospitalized. So it's all a reflection that we're going in the general good direction in some areas of the state, but again, a lot of other areas that are not doing so well. Just to be clear, the city is still instructing residents to remain at home except for essential trips, wear face masks in public, and frequently washing their hands and practicing social distancing. Just a quick website for those of you who don't know, is this COVID-19 website. It gives you a sense of where you can go, and there's a lot for testing. There's a lot of centers out there with good availability now that things have generally calmed down a bit. There's a screening questionnaire, and it'll take you right to where you can go for mostly free testing, and even for, I think, asymptomatic screening as well. So continue to please support our chapter of the Lupus Foundation. Continue to go to the website, look at all the different resources, including the COVID resources, as well as everything that in terms of resources that we need to live and to take care of those with lupus. And thank you, Terry, for that. And please continue to send your questions by 3 o'clock on Sunday. and we'll address them the best that we can. So with that, thank you all for your attention, and I hope you have a safe and healthy rest of the week. Talk to you again soon.